generalities, not into specifics. Okay.
Got it.
Good morning, everybody. And let's make sure that we are streaming on our Facebook page at the Hypertrophic Cardiomyopathy Association. Yep, I see us over there. And I am Lisa Salberg. I am founder and CEO of the Hypertrophic Cardiomyopathy Association. And today we are bringing you another episode of Tales from the Heart, a podcast from the HCMA. And once again, my guest today is Dr. Marty Maron, or I'll call him my co-host. How are you doing, co-host?
I'm doing great, co-host. Thanks for the introduction of and the new name.
I know.
I like it. Yeah, I like it.
I think we're doing this a lot, and it's a discussion, it's a conversation. Right. Before we dive into our conversation of the day, I just want to acknowledge some of our sponsors. Yep. Thank you to Cytokinetics, to Bristol Myers Squibb, to Tenaya Therapeutics, to Imbria Pharmaceuticals, for helping support educational programming for patients and the community at large about hypertrophic cardiomyopathy. So, having started with that, I want to tell you a little bit about what we did for HCM Awareness Month as a kickoff, and what I'm doing at the end of the month, and how we're going to pepper a lot of content and stories to help raise awareness about HCM. So for those who are watching, you'll see a picture. For those who are listening, you won't see the t-shirt. And it says, I got to pull it back a little bit. Not all those with HCM are grumpy like Otto. And on the back, we have this great HCM awareness logo for the month. And on February 2nd, which was my 6th heartiversary, we'll talk about that in a moment, we did a viewing of A Man Called Otto, the movie featuring Tom Hanks as Otto Anderson, who happens to have hypertrophic cardiomyopathy, and he's a little grouchy. He's having a rough time of things, but the HCM storyline is just really interesting. And we had about 100 people come out to a theater in New Jersey. We watched a movie together. They got t-shirts, popcorn, soda, and then we had a discussion about life with HCM afterwards. And we are going to be doing another viewing in South San Francisco on February 24th at 5 p.m. Pacific time. You can register online at the HCMA if you want to join us. Tickets are limited, so please act quickly. And we're going to have another discussion after the movie. And we're going to just talk about real life with HCM. We're not trying to be drama queens with complaining about a disease, but we need to talk about it. What does it really mean for our lives? And the more we talk, the more solutions we find to living a better quality life. So that's how I spent my heartiversary this year, Marty. Is that a good way?
Is there a better way?
I don't know. I actually brought my heart with me. I felt like we needed to be close that day. So she was in a bag watching Tom Hanks movie with me. I'm serious.
God. You're going into areas that are beyond my bandwidth.
I know. Sometimes she doesn't travel with me often. I do not carry my heart around all the time, but when she can be an educational opportunity, she makes an appearance. But it is kind of cool to walk around with your heart in a bag in some bizarre way. I know. So what's going on at Leahy for Heart Month? What are you guys up to? Any awareness opportunities? Any story sharing? What's going on?
Well, we talked with our marketing people about that last week, and actually they had reached out to us and we had reached out to them about the same time about that question. And so what we're going to be doing is featuring a couple patient stories, from our center over the last couple months that sort of highlight I think highlight really two things. One is, the importance of the impact of current treatments that we have for HCM in making patients' lives better, how they feel better, quality of life better, and really making sure that message gets out there as it's always so important to do. And also the second thing is, for us, since we had a recent move, highlighting, some of the unique aspects to our center for patients that are important for them to know about. So those are the two things that we're hoping to do and accomplish for this month.
Excuse me, that sounds fantastic. HCMA is featuring a story of the day or a warrior of the day. Right. I'm sure we probably have some crossover patient stories that we're sharing. And we're sharing with our partner organizations materials. We put out a great educational piece with an advocacy group that we work with out of DC called Patch, and that's the Partnership for the Advancement of Cardiovascular Medicine. I might have said that wrong. Sorry, Ryan and Allison and everybody if I said that wrong. But it's a nice little it's a little story on social media. What is HCM? And there's some great infographics on it. And it's already gotten like over a couple hundred shares and thousands of views in just a couple of days. So we're hoping that that goes far and wide as well. So anything that we can do to raise understanding of HCM and get the media to see us, get the real world to see us, I think is really important. So yesterday I did 22 interviews around the world, around the country. Matt Martinez joined us and we got out there and we talked about HCM in lots of different markets. A few of them I've thrown on social media and you'll see the clips. But they'll be coming out over the next couple of weeks up until and past HCM Awareness Day, February 22nd. So, Marty, I'm going to ask you a question that we didn't practice. You'd love when I do this. Patient stories. We know that so many of these families have amazing stories of triumph and some tragedy and a little bit of this, a little bit of that, without names and specifics. What are some of the scenarios that stick most closely with you and make you want to stay in the fight every day for these families? Who are those special stories?
Well, I mean, it's a great question. I mean, I guess, kind of thinking about that as you were talking, the first thing that sort of came to my mind were, these families that have been incredibly impacted by the disease through multiple generations, right? I mean, we see that, right? Where you've got multiple generations, multiple people in each generation affected by HCM, sometimes in different ways, right? You can have some what we call these sort of malignant families where the mutation for HCM in that family is one that really is unfortunately created a number of adverse consequences for different members of the family across these different generations. And it's always very striking and very impactful to see that, when we see it in clinic and talking to the families in clinic. And so when you're sort of raising that, I was thinking, there are families, for example, that have had multiple different family members who have suffered sudden death, as well as multiple different family members and some families that have had progressive heart failure requiring transplant. Some families have both, across different generations too. And so it's really amazing to see, as you were just saying, how some of these family members with HCM living in these families persevere despite the weight that family history plays on them sometimes. And I think we spend even more time perhaps in those situations helping to provide, hopefully the right therapies to provide reassurance that despite that really awful family history, that we can still make patients safe and have them hopefully have the opportunity for normal longevity with great quality of life, despite the fact that it hasn't been that way perhaps in other generations for their families.
Yeah, I'm kind of one of those families.
Yeah.
I've kind of been there forever and you just want to make it stop.
Right.
Had too much power for too long. And, when I see families who are like mine and it's multi-generational, it breaks my heart in one way that, I understand that path very well. But those new families where they've never heard of it before and it's just coming up now, I almost feel like they're a little bit more blindsided that like they're not expecting this shit that is HCM life, right? They're not expecting all of this. And in our families, we're like, oh yeah, we've been there, done that, seen that.
Right.
They're new to this. And I always want to just kind of hug them and like, okay, it doesn't have to be as bad as it was for my family because we know so much more now.
That's right. We take more time in that situation to make that case to patients that it doesn't have to be like that. We live in an incredible era, even for HCM, where we've got interventions that can prevent those kind of complications from happening. And we really make sure that patients realize that, because obviously they, for obvious reasons, are overwhelmed by the history in the family and think that is a predestined in a way for them, but it's not. It's not. And maybe this is also a good time to you said something that kind of also triggered something on my mind too. You said you want to make it stop. and so maybe it's worth, at this juncture, just mentioning that there are available methods that can actually stop it from transmitting from one generation to the next, that have been around actually for quite some time as techniques that don't involve CRISPR, or these really advanced techniques that are sort of been talked about in the media in terms of altering genetic material, to stop transmission. But there are other ways to stop transmission. Do you want to just mention that, because that is a way to stop it?
I think that's a great way. And that was the first hint that we had, that we weren't curing HCM. We were stopping it from proliferating the family. So we were getting involved there. And that's pre-implantation genetic diagnostics, which the very basic explanation is you do in vitro fertilization, you test the embryo when they get to about 10 cells. And if those embryos are showing that they carry the gene for hypertrophic cardiomyopathy, they do not implant those particular embryos. They discard them. They're destroyed.
Right.
And then the good embryos without the mutation are implanted, and hopefully you get a baby free of HCM. And it's about 85 to 90% effective, because you are dealing with single cell data.
Right.
But it is a lot better than 50-50 right out of the box, right? So you hedge the bet. We know of a number of children created through this method. One of my favorite stories is actually, like, one of my favorite stories of all times. Back in the very early days of the HCMA, this mother called me. Her daughter had just survived a cardiac arrest at the age of 16 in high school, and just found out she had HCM. Marlene then became the first employee of the HCMA, and she worked in my house when the office was still in my house, because she believed so much in the cause. Her daughter went on to grow up, had a lot of malignant arrhythmias, and went to transplant at 24. And she didn't want to, it's complicated to be pregnant post-transplant. And they were going to go to surrogate anyway. And they did surrogacy with PGD. And they implanted an embryo, and it was growing into a lovely little baby. And then poof, 2 for 1, identical twins. And those identical twins are free from hypertrophic cardiomyopathy.
Yeah.
And that's amazing. Number one, that they're HCM free. Number two, that she got 2 for 1 on that deal. So we got 2 babies there who are now, gosh, the kids have got to be like 9 years old at this point. Maybe a little older. I haven't checked in with them in a while. So it's possible to stop HCM in some families. It takes a little bit of work. So you have to be committed to the cause if you're going to do that.
And some people may not, we have to obviously, of course, respect that some people may look at that technique in the terms of certain ethic and moral stance and not feel that that's the right for them. Yep. But of course, it's available, and that's super, super important. It's not something for the future. It's here now. It's been here for a while. And it can do exactly what you said. It can stop transmission. It's not a cure, but it could stop transmission. And for those highly malignant families, that could be really, really important discussion.
So on the ethical part there, I'm going to share a very unbranded story, but it happened, and I was really, really pleased with the way it turned out. So a woman called me about her son and wife wanting to have PGD, and she immediately defined herself as a devout, particular religion. I'm not going to mention which one, but that she was devout in her religion. Right. And that she had really big issues with this. And she wanted me to explain it to her again, because she just didn't think it was right. And we went through this conversation, and she asked me lots of questions, and I gave her additional resources. And at the end of the call, she said, "So God put this in place for us to stop disease. I'm good with it."
Yeah.
And I went, that's a beautiful way of thinking about it.
Yeah.
And they went on, and they had a PG. I'm like going to cry, because it was really a beautiful moment when she like took her religion and science and put them together and said, "Oh, there was something was damaged. We've got the repair. Here's how to repair it." And God must have put that in somebody's hands. I said, beautiful. I love it.
Yeah, that is a great way to put it all together. Yep.
So we can stop it with PGD. We
Right.
might be able to alter it with genetic therapies in the future. And today we have surgeries and medications and combinations of surgery and medication and lifestyle changes that really can improve lives so much.
Yep. That's right.
It's the game has changed a lot in 25 years.
Yeah, I mean, there's just no question about that. And, that's such an important point and principle. In fact, we start that way with our discussions with patients by telling them that, we have so much available today that we didn't before, that we believe that you can get to the end of the finish line with a great quality of life, with a normal life expectancy, almost all cases in this disease with those current options of therapies. Obviously, it's not for not every single patient, but we believe that's true, and I think you are also obviously been very much part of that message, and the distilling that message through the development of the centers, which are developed so that kind of message and delivery of treatment can be given to patients anywhere in the U.S.
So, good segue to my next point. If you told me 27 years ago when we come up with the concept of HCMA that we would be where we are today, I probably wouldn't have believed you, because that's a long way to go. But we're here, and we've got now 48 programs around the country specializing in HCM care. They're all a little bit different. Some have more strengths and skills and abilities and reach than others.
Right.
And some of them, I got a call the other day from a program that I talked to right before COVID, and he had 40 patients, and he thought that was a really good start. I'm like, oh, I'm not cute. So you got some growing to do and you got some learning to do. So he's called back now and they're up to 250. And that's nice, because the patients in his region are getting more organized care, and he's learning as well as a practitioner. But the rest of the system needs to be built, and it takes a long time to get the mechanics of running a center well. Good communication between clinicians at EP, interventional surgery. Go to work every day. You're working with people. I don't care what you do for a living, but the longer you work with people, the better you do the dance, and you understand everything.
Yep.
And that cohesive group and that mind trust and that belief system that guides what you do is critically important. So right now we've got, 48 programs. Your program relocated and kind of had a reboot to a certain degree, but you've got your core staff that's been together for a long time.
That's right.
And you guys can assess patients in such a way that patients don't get in the community. Your community cardiologist, God bless them all, they don't see what you see every day.
Right.
And they're not going to understand the nuances of each case like we need to. And sometimes I feel like I put HCM in a bubble and like, oh, we're so special, we're so different. But we are. And I'm not trying to be hyperbolic about it. Explain the parts of the heart that could be affected by HCM, Dr. Maron.
All of them. I mean, literally all of them. The muscle, the valves, the electrical. I mean, those are your three major components of the heart. And all three can be affected by HCM.
What other disease does that?
Right. No, look, you're absolutely right. And what you're sort of saying is that this is a disease that cuts across all the kinds of different disciplines of cardiology, electrical, the catheterization, surgery, genetics, all of them are involved in this disease. There's really almost no other example of another cardiovascular disease that transcends all of these different areas like HCM does. And that is really the reason why it's so important to put together a teamwork that involves all of these different disciplines, because you have to have that in a way to give patients the best opportunity for treatments and expertise that will allow them to achieve that goal of normal life expectancy with great quality of life.
Yeah, sometimes I want to think that, oh, we're overcomplicating it. No, other people can do it. And then I see what comes in the office and it's like, oh, no. We are going to
Yeah, we've talked about this before. We're not overcomplicating it. Actually, we're not even, we're not, we need to actually continue to move more in that direction, including incorporating other maybe less traditional aspects of care for the HCM patient, like mental health, mental health support, nutrition, exercise, all of these other areas, which also are involved in this disease at a very important level, not just EP, cath, genetics.
So I'm going to draw out my future perfect world. Are you ready?
Yeah.
So
Taking notes.
In this world, there is reimbursement and funding for the programs that I am about to lay out. And I do believe, as the former health plan administrator that's still within me, that if insurance companies and payers, Medicare, Medicaid, would see HCM more holistically, that they would save money in the long run with unnecessary trips to the ER and to the doctor's office when they're concerned about things that are normal for them, but still feel a little abnormal. So in Lisa's perfect world, a new patient with HCM, after identification of the HCM and assessment of anatomy by an HCM expert and risk evaluation, they would be offered an exercise class that would last about a month. And they could go 2 to 3 times a week and exercise under supervision to learn what normal feels like and what's safe for them, and to help them pave the road for, this is how I'm going to live my healthy life going forward. So they get a month of that, and then they would get an appointment for a mental health check-in with a therapist to discuss the emotional components of HCM and how they're balancing their life with this new reality of this disease that they have to partner the rest of their life with. Like, you're not getting rid of it. So I want to destigmatize, like, asking for, okay, how do I process this? How do I feel? My kids are now at risk. What did I do? It's a lot. Get some help. Life is complicated enough, and now I just added this on top. Let's get you some help. So then the patient gets that help. And then the patient doesn't have to go through 500 different phone calls to get their prescriptions every month. The prescription system and the PBMs will calm the hell down and let doctors prescribe what they feel is actually best for that patient and not give them fights about it. And then the patient should have an ongoing relationship with a nurse practitioner embedded within an HCM program, or a nurse or a PA or somebody else that they can have regular contact with, and ask questions and have dual, both way communication and establish a relationship, because we're in this for life, people. We're not in this for a transactional moment. We're partners. And we need to get on the same page. This is Lisa's future. This is what I want to see built.
Yeah, I love the vision, and I don't disagree with any of that, of course. And I think we need to continue to work to achieve that kind of goal and direction, because it's the right way to go. So I'm totally on board. I hear you 100%. In fact, a lot of our move was driven by those ideas, because we wanted to be able to go to a place where we had first of all, the physical space, the infrastructure to be able to provide HCM patients whose journey is over long, long periods of time, right? And so we want to be able to provide a place, physical place, where patients can come and can be able to receive not just expert opinions from, me, Ethan, or my dad, but also to have the other expert opinions come in, and that could also include, we hope someday, mental health and social and exercise, all under one roof, not having the patient go to all these different areas and maybe even different hospitals or different places or whatever, all under one roof in a comprehensive, individualized patient care plan.
And I think that is a future that we can develop out together. And this is where, like, my side of the road and your side of the road, they're parallels, right? We're there to support each other and make sure, that patients don't feel alone in all of this. It's a lot. I happen to, how am I going to say this? Facebook makes the world very small. So I'm aware of a family that we have in common that's going through some challenges right now in terms of somebody's going to need some surgery. And there's been a lot of trauma in the family in the past. And So I see what's going on there. So we're reaching out to make sure they have support through us as you're taking good clinical care of them and making this a little less burdensome as they go forward. These families deal with a lot. And sometimes maybe it's minimized or maybe it's not really appreciated because we're stoic and we just get through it. But while they're going through their thing, you guys are there too. You're going through it with them.
Right.
That has to have a toll on the team over time, doesn't it?
Well, I think it does. I think that's great for, great point. And thank you actually for bringing it up. I think we actually as a team talk about that sometimes, the toll emotionally and in some ways physically that is taken out of us in terms of being able to, just as you said, be able to deliver that kind of care consistently, reliably over long periods of time is a big challenge. I think there's a lot of themes going around right now in medicine, not just HCM, or cardiology, but in medicine of, what we call sort of healthcare burnout, right? And that's a real thing. And I think certainly COVID did not help with that. But even without that, I think there was a lot of concern about the cumulative effects that are taken out of healthcare providers when they have to deliver really high level care, complex high level care consistently and reliably in today's landscape. It's tough. And so we talk about that as a team so that people can vent and we can try to find ways to help us too, as well.
There are days here in the office where I'm listening to stuff that, reading autopsies with family members on their children, and you're like, this should never have happened. And you have to look for the lessons. I always take the downside stories, the negative stories, and I try to learn something from them.
Yeah.
And I've done that with every single person I've ever spoken to in my role here. And this year, for HCM Awareness Day, I met a family this week, and I was trying to figure out how to start my legislative briefing on the 22nd, how to make lawmakers really understand why it's important to ask family heart health history questions in the beginning of, the well child exam, to give a family an opportunity every year to talk to a healthcare provider about what's going on in their family. And this family came across my threshold this week. They lost their 17-year-old daughter, and she had been diagnosed, but the time from her diagnosis to death was like under a month. And the time that they could have been engaging with the healthcare community goes back like 6 years.
Right.
But local physicians said, oh, no, that's not your problem, and led the family down the wrong path.
Right.
But there'd been multiple sudden deaths already and complications, but nobody was asking specifically, is there a family history of hypertrophic cardiomyopathy? And if this family had been asked earlier, they would have been able to take action earlier. And instead of this young lady passing on that day, she would have had an appropriate ICD shock, and we would have called it a save and a win.
Right.
Timing matters.
100%. Absolutely.
And we're going to have this young lady's story be the catalyst of education. And there's so many other stories. We don't win them all. We don't. My family's lost a few.
Right.
And the ones we don't win, you got to take something from them to make the future better. This is what keeps me sane.
Yeah. Yep. You got to always learn from those so that you can be better going forward. There's no question, that is a really key message.
So one of the ways we're going to do that, I got more props to show you. I got fancy bling in the mail yesterday, Marty. I got a formal proclamation from Ned Lamont, governor of the state of Connecticut, with a lovely, long, complicated proclamation and a nice gold seal. I don't know if you could see that.
Yeah, that's amazing.
Okay, so we got that. And then we've got our framed General Assembly official citation. Thank you, the state of Connecticut, for HCM Awareness Day. So we've got 2 gold seals from the state of Connecticut, and I've got a shout out to the state of Indiana, who signed a proclamation yesterday recognizing HCM Awareness Day. and we passed the committees in Utah. So we're headed there. We got Texas done. We got New Jersey done. Massachusetts is coming next. So we're going the Proclamation of Awareness Day route right now, which will then pivot into the HCM Act in each of these states as a follow-up act. So changing
Amazing.
laws.
Amazing.
So yay.
Congratulations, really. That's amazing work. I'm kind of mind blowing that you got, that you've gotten to that point where you've gotten states to recognize and appreciate the disease officially like that. It's really amazing. Well done.
Thank you. More to come. And we have a little announcement time. Starting, I think it's next week, we have 3 interns joining us for our legislative advocacy work. And we are going to have a team of interns. So we'll have about 1,000 hours of labor contributing to passing the HCM Act in different states and start the ball rolling on that this year in a very meaningful way. So they start next week. So HCM Awareness Day, HCM Month, Heart Month. Oh, and we got different earrings today. Please notice from the or for the Big Hearted Warrior Tour, I had different ones on. But Rosemary made them both, and they're available for sale. And you can buy them, and she's giving a donation to the HCMA for Heart Month. So I have lots of heart earrings. Earrings.
I'm not an expert in that area, but I like the look of those. Oh,
I don't know. I think the wife needs a pair, Marty. No.
I'm gonna say I like those, and I like the ones you had on for the Big Hearted Warrior Tour this week too. So I like them both.
Okay, good. She has lots of different options, so whatever you want. So Marty, what else do you want people to know about Heart Month? What should they be doing? What should they be thinking about their hearts this month?
Well, I mean, I think maybe one. Look, there's a lot of answers probably to that, but one would be, one we come back to a lot, which is for those patients that, perhaps haven't yet or in a while checked in with an HCM center, to get the opportunity to perhaps, hear maybe more about the disease itself, but also hear more about what's going on in terms of therapies, what could be available to even make their lives better. And so I think, that may be a good theme to talk about here as well. Rechecking in if you haven't been in a while, or maybe some may have never been to a center of excellence. I think this is a great time to revisit that topic.
I'm in storytelling mode today, and again, going to mask this one on identity, but spoke to somebody else this week who said, my sister called you guys a while ago, and she told me I should go to a center of excellence, but I was stable. I've been diagnosed since I was a teenager. Now I'm in my 50s and I'm fine. So Spidey sense said maybe the sister was right. So we checked in with one of our centers down in Texas and found out that his very thick heart has now gotten a bit thinner and his ejection fraction has dropped. And he is developing signs that might be indicative of those who head towards transplant. Right. And he got there in time. He's assessing. He's getting information, he's getting his plan in order, and he can make a reasonable step potentially to the next part of his treatment rather than going there in a panic or, I don't know, maybe being a little bit in denial for a while, like some people might have been when they heard news like that from somebody once.
That's right.
I admit what I did wrong. I should have had a right heart cath earlier. I know that. And I warn, that's my cautionary tale to everybody's like, I almost screwed this one up. Please don't do the same as I did. Take early action, figure out what's going on. But you never know when things are going to change in a way that maybe you didn't perceive yet, but your heart is telling a story that needs to be heard. So let the specialist figure out what that story is and guide you properly.
Yeah, and to that point, there are, as we continue to talk about, therapies or interventions that should be considered then earlier than we've ever considered before in certain situations that may actually alter the natural history or the risk of going a certain direction in this disease that you would not get access to or hear about if you don't go to a center, right?
And what about clinical trials?
And yeah, of course, in clinical trials, it's just another great example of hearing a story about something that could be available to somebody that may help them beyond what's currently available. That's exactly right.
So we're going to talk about clinical trials on HCM Awareness Day and what the status of a lot of them are right now in HCM. We're working with multiple companies to help raise awareness about their clinical trials and help patients engage with those trials. What do you think patients really need to understand about the clinical trial process? Is it safe? Should they trust it? You know, do they want to, you hear the word guinea pig a lot. Oh, I don't want to be a guinea pig. But what does that really mean? I was in a lot of clinical trials. I never felt like a guinea pig. I felt like a pioneer in a sense. I was trying to help the future. So what do you think patients should know?
Oh, look, I mean, I think first of all, I agree. It's not. I think that it should not be looked at or described as being a guinea pig. I mean, that's I think a perception that I can understand how some people could have, but I don't think is on target exactly at all. That said, I'll just also say that that I don't think that clinical trials are necessarily for everyone either. Of course, that patients may still have very strong reasons or reservations about engaging in that type of treatment initiative. Okay. Doesn't mean they're wrong or that they're off at all. But I don't think it's a guinea pig issue though, of course, because there is an incredible process that's involved with clinical trials, not just in HCM, but clinical trials across all disciplines of medicine that we had in place that reflects decades of experience in getting us to be able to provide that option for patients in a safe way as possible, to provide the most assurance. Nothing's 100%, but a really high level of assurance that even though it is a clinical trial and that it involves to some degree a therapy that may not be yet approved, that the circumstances that patients are entering into when they do that involve numerous checks and balances that help to ensure as close as we can that the process will be safe for them. Okay. So I think so that's a point of reassurance. Again, it doesn't mean that it's still going to be right for everybody.
Absolutely.
Of course. But I think everybody should know that there is an enormous amount that goes into ensuring, as part of the process of clinical trial participation, that is inherent in the process that really does protect patients fully here. Okay. And for that reason, I think that, of course, the guinea pig issue or example isn't fair because it's not really on target for that reason. And that, look, and again, I think you have to individualize it for certain patients. Then I think that discussion should be had about whether or not it makes sense for them to be involved in a clinical trial, depending on their circumstances. And of course, that's a discussion you have to have with your center of excellence who may be participating in that particular trial to see if it's the right fit and makes the most sense for that particular patient.
So there are a number of clinical trials on the horizon or populating right now. So we're going to start talking a lot more about it here, because the only way we get to the finish line is meeting the recruitment. So you're going to need a certain number of patients to step up and do the work.
Right.
They pay for your time to a certain degree. Sometimes I think they cheapen out the patient experience a little bit. I remember spending a half a day in the hospital and getting a $50 gift certificate. And it's like, oh, that was nice, but I lost a half a day at work. So we do need to make sure that they're paying the patients appropriately for their time. And then some people will say that, oh, it's an undue enticement. To pay somebody what they're actually going to be making anyway is not an undue enticement. It's fair. It's their time. It's their body. They should be compensated.
I agree with that 100%. I've advocated for giving patients more support when that's come up at different times for that reason. Totally agree.
Yeah. And I think these are conversations I've had with members of the FDA kind of in different meetings over the times. I don't think there's a problem with paying people what they actually make and making it fair. So I'm hoping that the trialists are listening to us right now. That'll make it easier. But patients are going to have to give their time, and they're going to have to show up for those appointments, and they're going to have to answer questionnaires, and they're going to have to do the follow-up to make sure that we get to the end of the clinical trial. And we love you all. You're all little pioneers. Thank you so much for thinking about it and doing it. And this year, the HCMA's annual meeting in October, we're actually going to invite our industry partners to bring clinical trial coordinators on site to talk to patients face to face. So we demystify things, and you can ask the questions immediately to those individuals who are going to be doing the recruitment in a private way, and you can engage with them and meet them as human beings. Maybe have lunch with them too. Who knows? But I think much like we did in the early days of the HCMA meeting, I kind of wanted to take the bar down between the clinicians behind the shield and the patients out on the front end. I wanted to bring everybody together. Now we need to bring the industry folks in and the clinical trialists in, and have everybody really working together towards the goal. This is the future I want to build.
Yeah, that's right. I'll just, no, totally agree. I was at one other thing too. So it was kind of occurring to me when you were talking too, is that, look, the clinical trial is new for us in HCM, right? Historically, we haven't had this opportunity as part of HCM for the 60 years that it's been, a disease that's been recognized. It's only over the last 5 to 7 years where we've had any kind of discussion around clinical trials, because it's really only through the development of new therapies for HCM that there's been clinical trials brought to this disease. So it's new for us, but I just want to make sure everybody understands this is not new. And you step outside of HCM. Clinical trials have been going on in cardiovascular medicine for decades.
Long time.
Decades, right? And so some of the themes and spirit you hear around our discussions of clinical trials in this disease, in a way, kind of reflect that all of us are sort of new to this, but it's not new.
Yeah, the structure has been there. And in fact, it's improved for uncommon diseases. And we are still considered a rare disease, even though we're the most common genetic heart disease. We're rare because under 200,000 individuals in the United States are currently diagnosed and managed for the disease. Right. And if you wanted to splice it by gene, each gene could be considered its own disease. So we're still kind of considered in the orphan drug status, in the orphan disease status, rare. So our trials are a bit smaller than you'll typically hear in other populations. So coronary artery disease trials, they do what, 5,000-10,000 patients?
Right. Right. Of course, our numbers are lower because we just don't have as many patients in this disease as coronary artery disease, but the designs, the structure of them is very, very similar still.
Right. And are you watching any particular trials carefully, or what do you think is happening?
Well, I think, I'll talk to that sort of broadly, that, we obviously, have trials going on that are investigating the next version of myosin inhibitors. It's a drug called aficamten, made by a company called Cytokinetics. Like what happens a lot in cardiology is that there's a new therapy for a disease. It's called the first generation drug. And then other opportunities come up to potentially make a slightly different but similar therapy in that class that could have advantages or disadvantages compared to the first one. Okay, so we're seeing that now in HCM because we've got mavacamten, which has been approved as the first myosin inhibitor, and aficamten is what we call next generation version of myosin inhibitors, and it's currently under investigation, so it's not approved yet. It's in phase 3 studies. So it'll be very interesting to see. To answer your question, it's going to be very interesting to see what the results of that trial look like. How do they compare to the results of the mavacamten trials? Are there important differences that are clinically relevant? Are there advantages, disadvantages? How does it shape up compared to the first generation? So that's probably one of the big first kind of things that are going to come down the pike next in terms of clinical trial, what we call readouts for HCM. Okay. And then both mavacamten and aficamten are likely going to be investigated likely in non-obstructive HCM. Okay. And so that's the next, after what I just said, the next big kind of readout is going to be, are these drugs going to help patients with non-obstructive HCM? And if so, how? And what's the magnitude of that benefit, et cetera. So those are sort of the two big, things to look for as we move forward with these drugs right now.
I think both of them sound like really interesting and exciting. And I know many people who are participating in these clinical trials right now. And
let me interrupt one. Sorry, not to interrupt before I just because it's really important. There are also other drugs that are going to be that are being advanced, and meaning that are under investigation in HCM, as well, that you and I know about. This is all public knowledge. Imbria has a clinical trial. It's a company in Boston that has made a drug that alters myocardial energetics to make the heart more energetically favorable, and therefore may help patients feel better with HCM by optimizing the use of energy with that thick muscle that may in fact have an important role. We'll say it's under investigation, may have a role in making patients with non-obstructive HCM feel better as well. So there are also other drug classes being investigated.
I love the idea of focusing on cardioenergetics, whether you're talking about regulating myosin, which adds force, or altering ATP use. It's different philosophy or different mechanisms than we've thought about before. But as I've spent many hours trying to figuring out like why good days and bad days with HCM, why do we live on a roller coaster all the time? Why is a good day until it's a bad day and then it's a really bad day? I can't help but think it's about how much energy our hearts actually have to use to function. And there's just no energy left to function the rest of the body. So if the heart doesn't have to work so hard and there's not as much energy there, you've got it to use elsewhere.
Absolutely. Makes a lot of sense. Obviously, we need to prove that's true, but it makes a lot of sense on the surface. And by the way, too, the other point, too, is that the other kind of big direction we may be going is combination therapy. We're getting more tools in the toolbox, but maybe the answer is going to end up being that patients may require two tools, for example, to really get them to a place that they want to be with HCM. And so combination therapy, which is just starting to be looked at in trials, may also be really important.
And there's another company coming up that I met with recently. And their concept is about stopping fibrosis.
Right.
The mechanisms to stop fibrosis from actually even occurring.
Right.
So imagine if you can alter fibrosis and replacement and the myosin power and the way in which the heart uses energy. And we just put that in a little combo pill and sell that one out there and everybody will be better. Who knows what the future will hold? We have so many things working right now. So we have a question from Facebook. If you join a clinical trial, are you guaranteed to get the actual drug? Are they double blinded? Do you get extended use after the trial's done? I want to talk about how some of the companies have structured that.
Yeah, great question. So in general, almost always, let me start this on almost always, again, nothing's 100%, but almost always for clinical trials, when you agree to participate, you will then be what's called randomized to one of two different arms in the trial, treatment arms. One arm will be that you'll get the new drug that's being investigated, or you'll get placebo, meaning what we call sort of a sugar pill. And those are one of those two options. You get randomized to that one of those two, and that randomization, meaning which one you get, the drug or the water pill or sugar pill, is blinded, meaning that usually your doctor who is enrolling you doesn't know, the patient doesn't know, and that's kept under lock and key until the end of the study. Okay, and the reason we do that, not just in HCM, but in almost all clinical trials across medicine, is to remove, to the best that we can, bias, placebo effect. There's a real psychological benefit, sometimes impact, I should say, in terms of patients feeling they could be better, because they're just getting a pill. Okay, so we're trying to remove that so that we can really answer the question of, does this specific new treatment really make patients better, removing it or independent of any psychological impact? Okay. The other point I'll just say too then is that at the end of this trial, what many of these clinical trials do is that they offer patients, once they complete the study, the opportunity to then enter into what's called an open label extension. And what that means is if they participated in the study, whether they got the drug or placebo, at that point, they are given the actual drug. It's not blinded anymore. Everybody knows they're on the drug. And usually they get that drug for free until either it's FDA approved or the patient doesn't want to go on it. Okay. And so that's kind of helping to do two things: make up for the fact that a patient could participate in a clinical trial and not get the actual drug,
right,
with the idea that they will. And two, it allows the companies to have more time and more patients on the drug to get more information about efficacy and safety. So those are the two big points.
And they're really important points, because lots of people say, well, I want to do the trial as long as I'm guaranteed to get the drug.
Right.
And nobody can tell you that, because we need to be careful. And even through HCMA's social media platform, we do not, we block people when they start talking about, I'm on a trial drug and I feel X and Y, because we
Right.
don't want to give anybody false hope or expectation. And we don't want to bias the trial in any way as a community.
Right.
So I've gotten a little pushback on that. Like, well, we want to talk about our experience. You could talk about being in a trial and the appointment visits and, you know, having your blood work done or your echo done, but we really don't want you to talk about how you're feeling, because you can just kind of throw somebody else off by giving them the suggestion that that's how they should feel too. So that's why we kind of monitor that conversation within our community. And then at the end, when it's all unblinded, then we can all talk about it openly. So really important to keep scientific vigor here and make sure that we're not biasing anything.
That's right.
So clinical trials for the future, so much going on this year. So we're going to be back in person in October at the HCMA annual meeting in New Jersey. So Marty, mark your calendars now. October 21st is Patient Symposium Day. And we're building out our curriculum right now for that. So you'll be able to register soon to join us in New Jersey. Space is limited to 305 or 10 or something like that. So given our past meetings, you're going to want to register early for the day. And we're also going to do the gala that night. So we're going to take some work during the day, and then we're going to have a little fun and party during the night. Got some awards to give out and some fun to have and some patients and physicians to recognize. So mark your calendars now for that.
I got it down. I just put it in.
Put it in. It's a thing. And then February 22nd, join us at 11:30 a.m. Eastern time for our HCM Awareness Day legislative briefing, open to the public. And then we're going to go into some video content and some shout outs from all of our Center of Excellence partners and our partners in industry and in advocacy. So you're going to see a little bit more about what we've been doing during the day. And then at night, we have a great program set for you. We're going to talk about our new project, the Nest Project, which we'll explain on the 22nd. And we're going to have a discussion group on a man called Otto. We're going to feature a couple patient stories. We're going to talk about some legislative initiatives. There's so much going on here at the HCMA. I can't believe how busy we are anymore. And the amount of work that we're able to do in these different spaces, just been so fantastic the past couple of years with all these new partners to really be able to put the work out there to help people live better lives. So come hear what we're doing. Come see your families featured. Thank you to all who have shared your story during Heart Month. So I need Marty for 2 seconds after the podcast. So we're going to end now. Any last thoughts, Marty?
We covered a lot of ground today. I thought that was really great. And always great to join you and the patients to talk about these really important topics. So thank you for the opportunity. And
absolutely.
Yep.
Thanks, guys. And see you next time on Tales from the Heart.